Welcome to Be an Informed Patient, Navigating Survivorship Care. During this seminar, all participants will be in a listen-only mode, and there will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember that information provided in this web seminar is not a substitute for your physician's guidance and care. My name is Sarah Rothschild, the VP of Program Services, and I would like to introduce our presenters for today. We would also like to thank Decipher for their unrestricted educational grant for today's webinar. First, Crystal Denlinger joined the National Comprehensive Cancer Network, NCCN, as Senior Vice President, Chief Scientific Officer in April 2021. She oversees NCCN's oncology research program and the drugs and biologics and biomarkers compendia, and provides input into NCCN's other programs. Prior to joining NCCN, Dr. Denlinger was an Associate Professor of Hematology Oncology at Fox Chase Cancer Center, and in this capacity, she served as the Chief of Gastrointestinal Medical Oncology, where she managed the program's clinical and research efforts, the Deputy Director of the Early Phase Drug Development Program, and Co-Director of the Survivorship Program. Our next presenter is Dottie Sheed, a Senior Director of Patient Information at the NCCN. She's responsible for production of the NCCN guidelines for patients, and she monitors and maintains tracking schedules representing the status of the NCCN guidelines for patients in the development process and web publication. In addition, Ms. Sheed oversees the production of NCCN programs affiliated with the NCCN guidelines for patients, including the NCCN Know What Your Doctors Know webinar series and NCCN Animations for Patients. Ms. Sheed joined NCCN in 2000 and served as a guideline coordinator responsible for the development, update, and publication of assigned NCCN clinical practice guidelines. We are very excited that they are here to present today, and I am now going to turn this over to Dr. Denlinger to begin.
Hi, thank you, Sarah, for the kind introduction. And thank you to the Life Raft group for inviting myself and Dottie Sheed to talk with you today about being an informed patient by navigating survivorship care. I'll speak first about the general landscape of survivorship care and the things that a cancer survivor should be thinking about and considering, and then I'll turn it over to Dottie, who will walk you through the NCCN patient guidelines for survivorship and the process of thinking through those guidelines. So we're going to start by providing an overview landscape of who are the cancer survivors in the US. There are approximately 17 million cancer survivors currently living in the United States, which represents 5% of the general population. Over 15 million of these survivors have lived more than 5 years since their diagnosis, and up to 20% and close to 20% have lived 20 or more years since their diagnosis. You can see in this graph here that the majority of cancer patients or cancer survivors are actually over age 50, and that over the next 20 years, we should see a significant increase in the number of cancer survivors. So this is a population of people in the US that are growing by leaps and bounds. We know that the post-treatment reality for cancer survivors is not a smooth road. Based on recent data from a large database of cancer survivors conducted over the past 20 years, we know that cancer survivors experience an increased rate of other medical problems compared to the general population. The most common medical problems that cancer survivors face are things like arthritis, high blood pressure, and heart and lung diseases. We also see increasing rates of diabetes, liver disease, kidney disease, and obesity in this population over the past 2 decades. In addition, the burden of having multiple medical problems is more common in survivors over time, and this is especially true in our young survivors. Cancer survivors are also at a higher risk of developing a second primary tumor or a new cancer unrelated to their first cancer. And this is likely due to a combination of shared risk factors, genetic risk, and potentially even previous treatment that they've received. And we know that most second primary cancers develop in an organ outside of or different from the organ in which the first cancer developed, and that lifestyle risk factors and health behaviors can actually drive the development of some of these cancers. So things like alcohol use and tobacco use. We also know that survivors may have variable health maintenance, which means they may not have they may have low rates of immunizations, so age-appropriate immunizations. Cancer survivors may not always be getting the cancer screenings that are recommended for their particular age and gender. And they may also have lower rates of cardiovascular disease risk management, which is important because cardiovascular disease is actually a very common problem in the cancer survivor population. We also know that survivors are at higher risk for productivity loss and increased economic burden, and this increases over time as well. There's a high risk for survivors going through treatment to retire early or not return to work after completing therapy. And so this is an overall picture of survivors such that they have a number of issues that they face when they complete their treatment. Survivors also face a lot of late and long-term effects specific to their cancer and their treatment, and this may actually impact their future quality of life. So late effects are toxicities or side effects of treatment that are not obvious or present at the end of therapy, but go on to develop at a later time point, and they are directly the result of the treatment that they've received. So for example, for a head and neck cancer survivor who may have received radiation therapy to the neck, the development of low thyroid or hypothyroid function is a late effect. We also have long-term effects, which are side effects or complications of treatment that you must compensate for during treatment. These effects arise during treatment and then persist after treatment completion. And this may be things like numbness and tingling sensory neuropathy of the fingers and toes that is related to a particular chemotherapy agent that one received. Late and long-term effects encompass things like impaired organ function, the two examples I gave before, but it also can incorporate things like psychosocial distress, sexual dysfunction for young survivors, infertility, cosmetic changes for those who may undergo a body-altering surgery, mobility limitations, and can also encompass things like communication and cognitive issues. As I noted before, health behaviors and lifestyle factors may actually drive some cancer developments, not all, but some diseases. And there is data looking at cancer populations from 2013 and 2007 to 2010 that shed some light on the health behaviors of the cancer survivor population. We know that about a third of cancer survivors are physically inactive, which means they're not getting routine physical activity in their daily life. We know that cancer survivors are more likely than the general population to report sedentary behavior or sitting for more than 8 hours a day. We know that about 2/3 of cancer survivors have either overweight or obese body types, and the majority, almost 83% of cancer survivors, do not consume the recommended servings of fruits and vegetables per day. And so these are all health behaviors and lifestyle factors that contribute to the development of some cancers and are potentially modifiable to improve health outcomes in the survivor population. So why do we talk about these things? Because health behaviors actually can have a long-term impact on things that matter, namely survival. While there have not been studies specifically in patients and survivors of sarcoma or GIST, we do have some studies looking at breast, colorectal, prostate, and lung cancer. And these studies have looked at body weight and outcomes and have demonstrated that those who have an overweight or obese body type have a lower survival and higher risk of recurrence in breast, colorectal, and prostate cancer, although having overweight or obese body habitus is associated with a better survival in lung cancer patients. In addition, there was a recent study that actually looked at diet quality, looking at a high quality diet where you ate a lot of fruits and vegetables, stayed away from red meat, versus a poor quality diet. And this demonstrated that in the cancer survivor population, higher quality diet was associated with lower cancer-specific mortality, meaning death from a cancer, as well as lower all-cause mortality, meaning death from any cause. And this again looked mostly at the breast, colorectal, and prostate cancer settings. We also know from data that I don't show here, poor nutrition can actually be associated with poor outcomes for patients undergoing surgery and chemotherapy. So even when you're on treatment, trying to maintain a healthy diet and a good quality diet is associated with better outcomes. So what about physical activity? I talk about this a lot because physical activity has been studied extensively. Again, prostate, colorectal, and lung cancer patients and breast cancer patients. And we know physical activity after a diagnosis may impact outcomes. And the good news about physical activity is that this is something that you can change even after a diagnosis. People can always become more physically active or less so after a diagnosis. And I will impress upon you the importance of maintaining or improving physical activity after a diagnosis. Because while it has not been studied in most diseases, we know that physical activity after a diagnosis of breast, colorectal, or prostate cancer has been associated with lower risks of recurrence and lower all-cause mortality, meaning that people are less likely to have recurrence of their cancer and they're less likely to die from any cause. An analysis of studies that have looked at patients with advanced cancer, so metastatic cancer or cancer that is not considered to be curable, post-diagnosis exercise did not necessarily improve outcomes, but there are some observational studies that have looked at the amount of exercise an advanced cancer patient engages in, suggesting that outcomes are better in those who exercise. Studies really have not been done specifically in sarcoma in just survivors, but it's well known that physical activity lowers the risk of dying from cardiovascular disease and other medical problems in the general population. And as long as you feel comfortable and can safely perform physical activity, we think physical activity is an important component of survivorship care. So why am I telling you that physical activity is important? Well, we know that physical activity not only improves cancer-specific outcomes, but it also can prevent certain cancers. So there have been 7 different cancers for which physical activity engagement has been shown to lower the incidence of or the development of. So breast cancer, endometrial cancer, kidney cancer, bladder cancer, esophagus cancer, stomach cancer, and colon cancer have all been associated with lower rates in those who are more physically active. And since we already talked about the fact that survivors may have higher rates of second primary cancers, physical activity may impact the development of these tumors. We also know that physical activity improves general quality of life, fatigue, and may also improve other things like sleep, cognitive function, et cetera. We talked about the fact that survivors have a risk of second primary cancers, and this was actually a study that was very recently published, looking at survivors from 1992 to 2008, which demonstrated that approximately 8% of the cancer survivor population will go on to a second cancer, most of those occurring in people who are over age 65. The most common cancers diagnosed in the cancer survivor population were the most common cancers we see: breast, colorectal, endometrial, bladder, kidney, and lung, many of these diseases with a health behavior component to their risk. The most lethal of these cancers is lung cancer, and we know that over half of cancer survivors will actually die of their second cancer. And as you can see from the graph that encompasses all survivors of one cancer, the types of cancers that we see developing in this population is very varied, some of which have screening recommendations like colorectal and breast, and some of which obviously we currently are not able to screen for. And factors that affect the development of the second cancer may be multiple and include genetic risk, environmental factors, treatment-related factors, and health behaviors. So now we're thinking about cancer survivorship. We know that this is a population with increased risks and potentially increased needs. And we know based on a seminal publication from 2006 that there are 4 essential elements of cancer survivorship. The first is surveillance, and this is looking for the recurrence or the spread of the cancer that you've already had, as well as looking for the development of new cancers over time, and assessing for both the medical and the psychosocial late and long-term effects of treatment. The second essential component of survivorship care is prevention, and this is prevention of both recurrent and new cancers, as well as late effects of treatment if possible. This is where your lifestyle behavior modification can be important. The third is intervening for the consequences of cancer and its treatment, whether it be medical problems, psychosocial problems, financial or practical concerns, or other symptoms that arise from treatment and the cancer. And then finally, coordinating all of this care between the oncology specialist and any other medical specialist and primary care physicians or PCPs is important to ensure that all needs are met. And I would say that for survivors living with metastatic disease who also go through a lot of these similar things that we've just talked about, all of these essential elements are important for them as well, although perhaps the focus on new cancers may not be as important as focusing on the cancer they're currently living with. Looking at it another way, survivorship is really three buckets. There's prevention and promotion of health behaviors. There's detection of recurrence of the cancer or second cancers. And then there's the management of side effects and late effects. And that can include the management of things like pain, cognitive dysfunction, organ function, or practical issues that the cancer has affected. Now, the focus on these buckets can change over time. So in the first year or so, the oncology team and you as the survivor are really focusing on the treatment and the plan of your care, potentially making it through the treatment and going on to rehab or rehabilitate from any side effects. As you finish that first year and move into the sort of acute phase of survivorship care, the first few years after your diagnosis, now we're really thinking about surveillance for recurrence of the cancer that you had and addressing and rehabilitating any of the effects of the treatment and the cancer that you had. And then finally, as we get past that 5-year mark where maybe the risk of recurrence of the previous cancer goes down, now we're starting to think more about other diseases where the cancer is part of the history that we need to consider, but that forward thinking, we've got to think about other medical problems, other cancers, and continuing to manage other comorbid conditions or chronic conditions. And throughout this whole period of time, we need to be thinking about health behaviors and promoting good, healthy habits and working on preventative health. So getting your immunizations, your cancer screenings, and other things. So how can you be an informed survivor? I think one of the first things that you can do is develop a survivorship care plan. And this can be something that either you do or something that you do in conjunction with your oncology provider or that they provide to you. A survivorship care plan includes some very basic elements that should be part of every plan. And the first is who are the oncology providers and physicians that took care of you, and make sure that you have their names and their contact information. You should also have a summary of your cancer diagnosis and the treatment that you received. And this includes not only the name of the cancer that you had, but any molecular abnormalities that you may have. So if you have a c-KIT mutation or if you have another molecular mutation. It should include all of the therapy that you received, surgery, radiation therapy, chemotherapy, targeted therapy, and when those therapies started and ended, as well as any genetic risk assessment that you may have had. So if you had gone on to meet with a genetics counselor about a family risk, and know those test results as well. The third thing that's important is to know the surveillance plan for your particular cancer. How often do you need to be seen by your doctor? What blood tests do you need to do? What imaging studies do you need to do? Are there any other specific tests? I do GI cancers. So for my colon cancer patients, we recommend colonoscopy on a routine basis after colon cancer therapy, but we don't recommend it for gastroesophageal cancer, for example. And then finally, wellness recommendations, so that you know what other cancer screenings you're supposed to have, what healthy lifestyle behaviors you should engage in, and making sure that you're getting the appropriate immunizations. So for surveillance, detection, follow-up is key. And surveillance is really dependent on the cancer that you had. So a sarcoma patient, a soft tissue sarcoma patient, since there's a variety of soft tissue sarcomas, they may have different recommendations based on their histologic diagnosis that may differ from a GIST patient. But in general, we typically recommend a history and physical exam every 3 to 6 months for 5 years and then annually afterwards. And you may also then need to get a CT scan every 3 to 6 months. And if you have a very small or low risk tumor, maybe you don't need as frequently imaging or as frequent follow-up. And we know that survivorship care is not just about the oncologic follow-up, it's also, about good primary care. So we want to make sure that you're seeing and connected with a primary care doctor for the health maintenance and preventative needs that you have. As part of surveillance, we also need to be thinking about genetic risk and familial risk. We're learning more and more about risk factors and causes of cancer, and there are all the time developing familial syndromes that may encompass a wider combination of cancers. So people who may have a higher risk of familial cancer syndrome include those who were diagnosed before age 50, those who were diagnosed with multiple cancers, those with sequential generations in which there were multiple cancers, and certain ethnic groups. And family history is really important to help identify where the risk might be heightened, but it's also a very fluid topic. So it's important that you keep your oncology providers and your primary care doctors up to date with your family history and review your family history regularly when a new cancer diagnosis arises. We know that survivors are at increased risk for second primary cancers, so there are a number of cancer screening recommendations. NCCN has cancer screening recommendations for breast, colorectal, prostate, and lung cancer. And the American Cancer Society, or ACS, has recommendations for cervical cancer screening. These are periodically updated, and I'm not going to go through them in great detail, but suffice to say, based on specific age, you may need to start screening for one of these cancers. And the most recent update has really been to the colorectal cancer guidelines in terms of screening. Now screening starts at age 45 as opposed to starting at age 50. The USDA and the Department of Health and Human Services recently updated their guidelines for diet for all Americans. And the guidelines used for diet recommendations, all Americans, are the guidelines that any cancer survivorship recommendations are based on. Both the American Cancer Society and NCCN have guidelines on health behaviors in diet and cancer survivors, and it's based on these USDA recommendations. This is from their latest publication and really sums up how you should approach your diet. Basically, everyone should follow a healthy diet pattern throughout life, at every stage of life. And it's important to customize your diet to your particular taste, but also think about low calorie and nutrient dense foods, and really work to ensure that you're meeting your preferences, but also trying to avoid things that are high in sugar, high in saturated fat, and high in excess sodium. We also have learned more that alcohol intake may have an impact on cancer development. And so we more and more guidelines are recommending limitation or abstinence from alcohol intake. Third, we want to make sure that we should meet your needs with whole foods. So instead of taking a supplement or a pill, most of the nutritional needs for a cancer survivor should come from food as opposed to supplements. And you're really going to focus on those nutrient dense foods and low calorie foods. And it is important to actually pay attention to calories and portion size nowadays. And again, limit foods with excess sugar. NCCN survivorship guidelines address nutrition and weight management and recommend achieving and maintaining a healthy body weight throughout life using a three-pronged approach: caloric management, physical activity, and behavior modification. And so what does that mean? That means that we should consume a healthy diet. Your diet should be about 50% plant-based and really limit how much red meat and processed meat you're taking in. It should also limit how much refined sugars and processed foods. If you live in the Philly area, there's now a sugar beverage tax, and that may help deter some of the excess sugar beverages that you take in. And we also recommend minimizing alcohol intake, if at all. In terms of behavioral modification, that also means tracking your calories, understanding what your caloric intake should be, and making sure that you're taking in a good amount of calories. And also pay attention to your snacking habits, the timing of your meals, and your portion size. What your plate should look like is about 50% fruits and vegetables, about 25% grain, 25% protein. And the USDA has a really nice app, choosemyplate.gov, that can help you guide food choices. In terms of healthy lifestyle recommendations for physical activity, again, NCCN and the American Cancer Society have guidelines for physical activity, and the current guidelines are to get at least 150 to 300 minutes a week of moderate intensity or vigorous intensity exercise spread out through the course of the week. And they include a variety of activities such as the ones I've mentioned here. And we also recommend the use of strength or resistance training at least twice a week and stretching. But most importantly, even if you can't make 150 minutes a week of exercise, which many people can't, avoid being inactive. Get up and move, engage in some form of physical activity every day. We also talked about health behaviors involving immunizations, and we know that cancer survivors may be at risk for certain infections, or maybe at higher risk for bad outcomes if they develop an infection. And so we know that all survivors should get their annual flu vaccine, should stay up to date on their tetanus shots. At certain ages, the zoster vaccine and the pneumonia vaccine may be important. In today's day and age of the pandemic, the COVID-19 vaccine. And ideally, you want to get vaccinated before you start therapy, but even if you get vaccinated during therapy, some degree of immunity develops, and it's still better than nothing. So you need to talk to your doctors about what vaccines are necessary and the timing of those vaccines in relation to your treatment. The one other thing that is important in cancer survivors is returning to work. So many survivors, sarcoma patients, sarcoma survivors specifically, may actually want to return to work. And it's important to make a plan for your return to work period. NCCN survivorship guidelines also have information on returning to work. And it's important in that plan that you discuss what your needs are, what your goals are, what type of job you're doing, what are the things you must be able to do to return to your job, talk about what symptoms you might have or develop during the course of therapy and how you might address them. And you also may need to talk to your employer or research programs that involve rehabilitation. So it's important to sort of proactively plan for return to work. We know that survivors can be cared for in a number of different models, and this may be a separate clinic where after a certain number of years you get referred to survivorship clinic, and this may be provided in a setting outside of the one that you received your treatment in. You also can be provided care in an integrated clinic, which is where you get your survivorship care in the same clinic where you had received your active treatment. And then there may also be multidisciplinary clinics where multiple providers would see the patient on the same day. In all of this, really, shared care is important. We know that involving both oncology providers and primary care providers results, in the best outcome for our cancer survivors. So shared care is best care. We also know there are a number of survivorship resources that people may need, including symptom management clinic, rehabilitation programs, mental health support, tobacco cessation, fertility support. So you need to talk to your local oncology providers about what resources are available for cancer survivors. And then finally, in closing, before I turn it over to Dottie, I just wanted to remind you that, the good news is that we have an increasing number of cancer survivors. The bad news is that they are now living longer with more increased complex medical needs. And comprehensive shared care really results in those best outcomes. Optimal management includes surveillance and risk management for cancer-related issues, in addition to managing all the other medical problems. And that means you need both oncologists like myself, as well as a good primary care doctor. Health behavior and preventative health should be a high priority for all cancer survivors. Again, avoid physical inactivity, eat a healthy diet, don't smoke. Didn't talk about smoking, don't smoke. Don't start smoking, and if you are smoking, please quit. It's associated with continuing to smoke during cancer therapy is associated with worse outcomes. And we know that survivorship care resources exist both nationally as well as locally. So you should talk with your oncology providers about what survivorship resources exist for your particular diagnosis and in your particular region. And with that, I'd like to thank you for your attention. And I'd like to turn it over to Dottie to talk about NCCN's patient guidelines. I'm going to stop sharing. All right, Dottie, it's all, the floor is yours.
Okay, so I apologize for that delay. It never fails right when it's my turn to present. An Amazon or somebody comes by and my dog's went a little crazy. So, but with no further ado, thank you so much for having us today. I believe better communications is better outcomes. So I want to just take this time to go over how to use the NCCN guidelines and also patient information. We're going to learn a little bit about the importance of our clinical practice guidelines, how to use the guidelines for patients to be a more informed patient or caregiver. And hopefully by the end of my presentation, you'll have a better understanding of what drives us, why it is so important, and how the guidelines can be used as a really valuable resource. So let's get started here. So who we are. NCCN is an alliance of the leading cancer centers devoted to patient care, research, and education. Our mission is to improve and facilitate quality, effective, efficient, and accessible cancer care so that patients can live better lives. And our vision is to define and advance high quality, high value, patient-centered care globally. So, and although our reach is global, it all happens here at the NCCN headquarters located just outside of Philadelphia. So as I said, NCCN is a not-for-profit alliance of 31 leading academic cancer centers in the United States. So this is just a map depicting all of our members and their locations. So that was just a little bit of background on what NCCN is. And now I'm going to just transition and talk about the NCCN clinical practice guidelines in oncology. So NCCN develops and communicates evidence-based recommendations to better inform the decision-making process between patients and healthcare providers. So the clinical practice guidelines, there are 82 NCCN guidelines, and they feature over 206 algorithms, and they apply to 97% of all cancer cases in the United States. There are guidelines for preventing cancer, cancer screening and early detection, treatment, survivorship, and supportive care issues as well. So the importance of all of this. The NCCN is the gold standard in cancer care. They are recognized, they are the recognized standard for clinical policy in cancer care in the United States. They are the most up-to-date information. They are updated frequently, really after major meetings, FDA approvals, any major area or breakthrough in clinical care, the guidelines get updated. They are widely available for free of charge for non-commercial use. And they are a tool used by payers. So they are the basis for insurance coverage and policy and quality evaluation. They can be accessed at nccn.org/guidelines or via a mobile app. So the expertise of the guidelines comes from each of the 60 guidelines panels. So of those 31 member institutions, there are representatives from each one that comprise the guideline panel. These panels meet and they participate in developing and updating the guidelines. It is estimated that they put collectively over 40,000 hours in developing our guidelines. That was in 2021. So there is a lot of work, a lot of expertise, a lot of evidence, and millions of discussions that go into these guidelines. The panels are multidisciplinary panels, having specialists in every area across the oncology continuum. So next, I'd like to go right into our guidelines for patients. So the clinical practice guidelines are guidelines that are developed by the panels, and they are, there's no funding from pharmaceutical companies or elsewhere. There's a firewall that protects them. They are created based on our member institution dues. The NCCN guidelines for patients is funded from the NCCN Foundation. They aim to provide cancer treatment information in easy to understand format for people with cancer and for those who support them. The NCCN guidelines for patients are designed to help people with cancer talk to their doctors about the best treatment options. So they are based on those clinical practice guidelines. They are easier to read, written in plain language, just to encourage a conversation between you and your healthcare provider. So this is an overview of the development process of the patient guidelines. There's a lot of steps that go into them. As I said, the prep work they're based on the clinical practice guidelines. So our medical writers have to read the current versions. They have to understand the algorithms, the diagrams. They determine what content is relevant for patients and caregivers, and they convert that into the easy to learn format. They really like to weed out like what is nice to know, but what is really needed to know for everybody. They collaborate with our clinical guideline coordinators, oncology scientists, and pharmacists, and they clarify and answer questions to any of the recommendations that are within those clinical practice guidelines. So of course, they develop a draft, they adjust it for appropriate reading levels and apply health literacy principles. The guidelines are then sent for a medical review to our panel members. And we work with an amazing graphic designer who lays them out, and it makes it look so appealing and easy. You want to read it, they're easy to understand. They're always reviewed and revised, and they are posted on our website. They are on an app, and they are also available on Amazon.com. And of course, we have a survey, and we really encourage everybody to provide feedback. And we update the guidelines based on the updated clinical practice guidelines, as well as the feedback that we receive from patients and caregivers and any patient advocacy groups or anybody that really just wants to share what, how these books have helped them or what we could do to improve them. So as I said, they are an authoritative resource. They are evidence-based and unbiased because they use the clinical practice guidelines for their development. On page 2 of every patient book, you can see what version of the clinical practice guideline it was based on. They go through a rigorous medical review process. And then we also, as I mentioned, really consult with our expert staff of pharmacists, nurses, oncologists, and our design layout. The audience, we apply health literacy and numeracy principles. They're written in plain language. All medical jargon terms and acronyms are defined, and they also are written in order to reach a large and diverse audience. The content outlines from testing through staging, diagnosis, treatment, and we offer suggestions and questions to ask your doctor. These are a tool to really have that conversation with your healthcare providers and be a part of shared decision-making. The layout and design, we're applying some ADA design and the health literacy principles. And we also are really making strides to make sure that they are inclusive and diverse in illustration and format. So the NCCN guidelines for patients, they empower family by putting patients and providers on the same page with the same information. They ensure that patients, no matter where they live, they are treated and where they are treated, that they know that what the experts agree is the standard of care. Ensures patients are aware of all of the treatment options and allows patients to self-advocate for their own best care. Just some points of pride. Like they said, I've worked at NCCN for over 20 years now, and this program is really near and dear to me. So currently having 61 guidelines for patients currently available that are for treatment, screening, and supportive care recommendations. That's it's just been amazing, the growth. There are over 40 translations of the guidelines for patients into 13 different languages. They've over 2.2 million downloads by over 1.5 million unique individuals, and 3,300 free books have been, 33,000 free booklets have been distributed. We do have the survey and we want feedback, and so far all the feedback that we've received has been fantastic. 95% helpful, 92% of people using them agree that they are trustworthy, and 95% agree that they were understandable. These are just some patient quotes or feedback. And this is our current library of guidelines for patients. As I said, there are the disease treatment guidelines, guidelines for supportive care, cancer screening, and age-related guidelines for adolescent and young adults. The guidelines are available free. You can read PDF online. We have a mobile app, and then you can also get print copies from Amazon. I love the mobile app. I use it frequently whenever a family or friend asks me or has a question. You can pull up the mobile app and just send that guideline right to them. It's very easy, it's convenient, it's my favorite, and most importantly, it is free to all. So let's take a closer look. The library of NCCN guidelines for patients includes the specific treatment books. So this is a soft tissue sarcoma book, prevention and early detection, supportive care topics such as survivorship, and age-related recommendations tailored for specific populations such as the AYA. Each book has a similar design and layout for ease of use and can be combined as complementary resources or used individually. The treatment books answer three main questions. The first is, what is it? So on the first chapter, you'll get basic information. The second question is, how is it diagnosed? So this chapter would go into detail about what type of tests that may be performed, how to prepare for that testing, and what to expect during an exam or procedure. And then lastly, what is the importance of the information that they find from the testing? And then the third question is, how is it treated? So different treatment options are described, and then they also provide recommendations for the best outcome. So as I said, this is a clinical practice guideline for survivorship. This is NCCN survivorship guideline. So we take the information from this document and we made 2 guidelines for patients because it's so much information. It was very easy to divide it into 2 really helpful resources. So survivorship care for healthy living and survivorship care for cancer-related late and long-term side effects. So the information is presented in small sections. So it allows readers to either read the book straight through or to skip ahead to sections of specific interest. The chapters are then broken down a little bit further. So each beginning of the chapter lists what is discussed there. But we also use a navigational feature. We refer to them as breadcrumbs. So as you can see on the top of the page, it'll show you exactly where the reader is within the booklet. It's also used as a design to help reinforce some of the information. It can be used also to just help locate information, especially for people who tend to scan information first and then read. So. Also on this, as you can see on this spread, so here is some of the text that is explaining. We use images, and this is a sample over here of a guideline that was all taken out of the clinical practice and made friendlier for patients. So the integration of information. Information is repeated and reinforced throughout the sections of the guidelines by using these small guides, patient quotes, tips for achieving goals, and at the end of each chapter is a review section. And then where words are not enough, we always try to add any graphics to aid in the explanations when possible. I think it's funny that we both chose the same image with the choosemyplate.gov. And also BMI. These are just examples of what you can find in the survivorship healthy living book. So this one is actually from the late and long-term side effects. So a call to action. As I said, the patient guidelines are really a tool to use to have a discussion with your doctor. So it also encourages you to, take an active role in your care. So by just giving little reminders, these are just samples taken from several books, and I just put them on one page. They would never be so many on one page, but they're just little reminders to tell you, like, your wishes, your goals are important. Speak to your doctor, your care team, and make it known. Bring a list of your medications because they're going to ask you. So have it prepared. Take charge of your healthcare with that by doing simple things that won't be overwhelming, but also give you an active role in your care. Keeping a pain diary, So you can describe your pain and you have a baseline, you can compare it if it's better or worse. I do this, I have it myself, even though your charts there's a lot of electronic charts you can look up online. I have my old fashioned binder and folder with any healthcare information, any studies, and so does my 80-year-old mother, who I take to all her appointments, and we carry this binder with us. So just little tips and things that are also included in these guidelines to help you. And then at the end, we also have questions to ask your doctor. I feel like while you're in an appointment, you can't think of it. It doesn't come to you, but when you're driving home, all of the questions come to you. So we have every one of the patient guidelines has suggested questions to ask, and they could be about different topics as well. And even you can print these pages out. You can have it on your phone because they're on the app, or however else you would want to use them. And then it also has just a little space for you to jot down some of your own. In the very back of our guidelines is the words to know. It's a glossary of terms. And it's just, obviously, it's just any words or phrases that are, or acronyms that are used within the text. It's just spelled out again for you. We also like to include additional resources and websites that would be helpful. Finding clinical trials, how to look for help to quit smoking. And then there are links to a survey that you can use to help us make our guidelines for patients better for everybody. So that is my presentation for today, and I thank you so much. And I am so happy to answer any questions. And if you don't want to ask them now, feel free to shoot me an email. I would be happy to reply. Thank you.
Thank you to both Dr. Denlinger and Dottie for your presentations. They were excellent. Dottie, feel free to, maybe you can unshare your screen so we can just see our images up. So this is the opportunity to type in the Q&A, any questions that you have. I'm just going to go ahead and get started. So Dr. Denlinger, you had mentioned at the beginning about more of a risk for kidney or cardiovascular issues. And I guess the question is, at least for the people who are on this call today, now they know to be more aware of it, but what's being done maybe policy-wise, or what cancer survivors need to know to be more alerted to these potential conditions, and how does that kind of get factored into clinical management? Because at least with the Life Raft group, I don't know how many patients sort of in their journey are told, well, you may need to be also looking at a cardio-oncology specialist based on some of the treatments that you're seeing. It doesn't really come up. So how do we empower or do something about that for the people listening today?
Yeah, so I think that's a great question, actually. And I think there are multiple stages along the treatment journey and surveillance journey where this can be revisited. So first, when someone starts a therapy, you get an informed consent document, which is a slew of potential risks and side effects of a treatment. And if you're, my experience having been on the oncology side of things is you give that whole list and you have the patient sign off and you hand them the document. But that was a lot of information in a very short period of time. And you're more thinking, and so is the oncologist, about getting started on treatment, and we'll deal with side effects as they arise. But I think when you finish a treatment and you're starting that survivorship plan, this is where that survivorship care plan can be really important, where you can now revisit the drugs that you've received, and you can ask your oncologist, so what things should I be looking at moving forward? So if you had received doxorubicin, for example, is there anything I need to know about for the chemotherapy I received? And for doxorubicin, one of the risks is potentially cardiac toxicity long-term. For patients who are receiving longer term therapy as sort of a maintenance treatment for years, how often do I need to get my blood work checked, and what kind of blood tests do I need to get done? So as you're finishing out or sort of entering that sort of more chronic phase of survivorship, this is a good time to go back to the book and and jot down your questions about now what are the things I need to be looking out for? What are the things that what testing do I need to be done? And what are the symptoms that I need to be reporting to you or to my primary care doctor as a survivor? And then, any symptom that is unusual or new or different than your normal, your sort of new normal, whatever that's going to look like. If you see things that are changing, it's better to talk to your provider than to stay silent. And the earlier, it's better to let the oncology provider, potentially the primary care doctor, or both know and let them help decide whether this is something that needs to be worried about or not. I think in terms of things like cardiac risk, I think there are two issues in the sarcoma population, one being, organ dysfunction related to the drugs that you've received. And for those patients, we don't necessarily preventively think about cardio-oncology follow-up, but we do want to make sure that our patients are telling us when new symptoms arise. But then there's also the second cardiovascular risk, which is more just regular heart disease that the rest of the US population is at risk for, which is something that our cancer survivors are at risk for as well. And so for those risks, cardiovascular disease risk, that's where we're monitoring blood pressure. So you should be getting your blood pressure checked at least yearly. You should be getting your cholesterol checked on a regular basis, and those recommendations will change based on age. But regular old cardiovascular risk management, hypertension, high blood pressure, cholesterol, screening for diabetes, looking at family history for cardiovascular disease and history of heart attacks or strokes in the family. All of that is important as well. So it's important to be working not only with your oncologist about the symptoms that may arise after your particular cancer therapy, but also with your primary care doctor to not neglect or forget about the risks, the family history risk, the personal risks that you might have for, cardiovascular disease,
Right.
as sort of a general disease.
Yeah, no, thank you. That was a great explanation. And I find that oftentimes we have our cancer survivors asking, well, I'm having some dental issues or some arthritis. Is this caused by the treatment, or is this my natural part of aging? And so I know that I'm sure this gets brought up in other diseases as well. And I think it's just hard. I think what you're saying is it's encouraged to talk to your primary care doctor
Right.
and to your oncologist about these things that are arising. And sometimes it's hard to determine if it's a bone density loss from natural aging or from the treatment, but just bringing it up is important so that they can monitor it.
Exactly. And I think that's, one of the things is, cancer survivors also age and have other medical conditions in addition to their cancer. And so sometimes it is hard to isolate the exact cause of why something develops, but it's more important to address the thing that arises. So making your providers aware and not suffering in silence, but talking to your providers. And, your oncologist is going to say, yeah, this is something that I can deal with. It's related to the therapy that I gave you. Let's talk about how to manage it. Or they might say, this is not related to the treatment or the cancer diagnosis that you had. So I'm going to ask you to talk to your primary care provider about that. And, that's why it's important, especially for younger adults who may not always have a primary care provider in their 30s and 40s, to be connected with primary care, because both of us have different levels of expertise. As an oncologist, I'm probably a terrible primary care provider, quite frankly, but I'm a really good GI oncologist, and my primary care providers are excellent at preventative health and managing, high blood pressure and diabetes, but they're a terrible oncology provider. So you need both expertise together because they complement each other really well. And we will hand off to each other, and we tend to communicate. In the world of electronic medical records nowadays, it's much easier to send a progress note to a primary care doctor. And if you're all on the same health system now, I work at Fox Chase on Friday mornings. I can access Epic health records of anyone in the Philadelphia area that's on Epic as well through Care Everywhere. So I can see primary care doctor notes now, and I can see cardiologist notes. And so the fact that we're better connected to each other also is better for shared care. So.
Exactly. Okay. The next question, I would say the theme is, how do you feel empowered to challenge the doctor with some of these recommendations. So I'm not going to go too much into the detail, but this patient has GIST, a rare form of GIST, and is in the 8.1% with 2 separate cancers. Also has a strong history of colon adenomas and 3 surgeries for them. She didn't agree with the colonoscopy doctor, who's separate from the GIST and lung oncologist in terms of waiting 5 years for the next colonoscopy, as the last doctor before him said annually. So what's the best way to approach your doctor and challenge them about these sort of recommendations?
Yeah, it is a good question. I think it is a hard question because as a patient, I can imagine that sometimes it's hard to question the person in the white coat in front of you. I think the best way to sort of deal with this kind of scenario is to be as informed as possible about your own disease. And that's where maybe some of these patient guidelines can be useful. So looking at what the appropriate recommendations are for a particular diagnosis or the surveillance recommendations for a particular diagnosis. And if you really feel uncomfortable with the recommendation that you're getting, maybe a second opinion would be within reason. I think that there's, it's not, I don't think physicians in general are averse to second opinions. And I think you should be comfortable with the care that you're receiving. And so if you do have questions or concerns, a second opinion is always reasonable because then you're going to be able to get a second sense, and they may agree with the recommendation you're receiving, or there may be a different recommendation, and then you have to feel comfortable about the provider that you're working with. So I think it's just really be informed, use the resources that are available to patients, and then, potentially ask the question as a second opinion.
Just one last question that came in, and maybe this is a re-clarification point. The person wants to know, are there survivorship programs by disease?
So I think it depends on where you get treated. I think in some places, in some cancer centers that maybe have a lot of resources and are very broad in their disease expertise, there may be disease-specific survivorship programs. Whereas in other cancer centers, smaller cancer centers, there may be a more generalized survivorship program. So it's not as if if the survivorship program is the same across the country. It differs by care setting. It might differ by disease because there may be, say, a defined survivorship program for a group of survivors that are a high volume group where you can staff a full clinic and support a full clinic. But for a group of survivors that maybe are a smaller group, they may still be seen within the context of their regular treatment clinic. But regardless of where the survivor is seen, either in a disease-specific or specific clinic dedicated to their cancer, or within the general oncology clinic, in the regular clinic that they had received their treatment, there are those essential elements of survivorship care, the specific points that should be addressed in survivorship that is really specific to the survivorship phase of treatment and differs by disease. So what I recommend for my colorectal survivors may not be the same as what's recommended for a GIST survivor, may not be the same as the recommendation for a breast cancer survivor, for example. So, and that's where these patient guidelines can be important because they will have the specific recommendations for the disease. And then you've got the larger survivorship guidelines or the age-appropriate guidelines, age-specific guidelines that might be more general for the particular setting in which you're currently living as a survivor.
Yeah, I can add to that just slightly. And it's along that same lines. There are several NCCN guidelines that are disease specific that do have survivorship recommendations in them. And then there's also our more general, our overall survivorship guidelines that I just went over with you today. So, and even the age related, the AYA one have some recommendations also for survivorship for that population because they have so many other issues that they have to deal with as well.
Okay, we're actually out of time. There was one last question about when the next updated GIST guidelines are coming out, but I can just kind of answer. I noted on the calendar that the sarcoma task force is meeting in September to look at that. So that probably gives us a hint in terms of when those updates meet. Oh yeah, Dottie.
And then I want to add as well. So when the guidelines get updated, the patient versions are due to be updated towards the end of this year as well. And when that happens, GIST will be a standalone. Because right now, in the soft tissue sarcoma guideline for patients, there is a full chapter on GIST. But after the update comes, GIST will be its own book. So
Okay, we'll look forward to
stay
it.
tuned, more to look
Yes.
come.
The LifeRef group will be in touch with the NCCN in order to share that information. But today, you were both extremely knowledgeable, and the presentations were excellent, because I feel like it really applies to many people in terms of really understanding the core components to survivorship. I think that they were really excellently laid out, and thankfully this presentation is going to be archived, so those who couldn't make it will be able to access it. So I want to thank you both for your time and dedication to present today. It was lovely to work with you both, and we hope to continue the dialogue with NCCN to help continue to make resources available to our patient community. So thank you very much.
Thank you for the invitation.
Be well, everyone.
Thank you, you too.
Yeah.